or wind? It's wind. Wouldn't it be great if all of a sudden I think I closed the outer door by doing that. And for the vein, there it goes again. It's going to whine the whole time. I'm not going to open this up. You can go over. The veins are deep with the same name. And then there's two veins you need to know about superficial drainage. For both the arm and the leg, the venous system is deep and superficial. I think it's important. So that's the easy part. The dreaded part is this massive nerve plexus that goes from C5 to T1 and supplies everything in the shoulder and the arm. And you just have to suck this one up and study it. It's hard to do at the beginning because you don't know where the muscles are. You just know what the hell the subscapularis is. Maybe if you have your lab, you've been trying to figure out where the muscles are, which we're going to cover all next week. So basically, it's the nerve supply for everything. And you should be able to draw it. You should be able to draw it out on a whiteboard and know where all these nerves go and who's supplied by what. Okay, because that's what we're going to do for the next couple of weeks before midterm, is just fill in all the muscles and the joints between the shoulder and the hand. And we're not going to get to the hand, the intrinsic muscles of the hand. I don't think we'll have time. We'll cover bits of the hand, the bones of the hand, some of the neat structures of the hand, but we won't finish the hand. That will have to happen after the midterm. So again, questions will come up to next Friday. Now, let's see. 1, 2, 3, 4, 5. 5 lectures left. Yeah, so 5 more lectures. Whatever that Friday is before your midterm, 14th, I think. So whatever we say there. So again, here's an example, a whole lot of information. I said you have to know. If you've been in the lab, you're going to start figuring out what some of this stuff is by looking at the parts of the scapula that are important, the parts of the humerus, radionoma, and the hand bones. We'll eventually get to those as well. So I put it up there to get you thinking, but you need to know the skeleton of the arm, because we're going to start layering all the muscles on top of it. We're going to talk about the glenohumeral joint, the sternoclavicular joint, the acromioclavicular joint, the elbow joint, and the wrist, including some of the joints in the hand that are critical for hand function. So we do spend time on the ligaments and joints, not as much on the ligaments of the hand because there's just too many of them. So, blood supply, what do you need to know? Well, heart's here, so an interesting landmark is that sternal angle. You think where you can find them from your notch, go down to the sternal angle, the sternal notch. Just to the left of that is the top of your heart. Intercostal space. Number 2 is the apex of the right atrium. Okay? So the arch comes off of the heart. And as it comes off, it supplies a whole bunch of vessels that go up to supply head and neck and the arms on both sides. Then curls around and goes down through the dorsal part of your chest as the thoracic aorta, through the diaphragm, abdominal aorta, blood supply bilaterally to all your legs, and everything else in between, liver, kidney, all that stuff. This is a very major artery. Okay? What I want you to know is coming off the arch, we have a right and left carotid artery. Okay? And actually the right one comes off a tiny little stump of an artery called the brachiocephalic trunk. Okay? So right and left carotid arteries, that's all you need to know. They go to supply the head and the brain. Okay? You don't need to know where they go. You don't need to know where any of these things go, except what they're called in what region. And what you'll see is the artery, it's just one continuous tube that changes its name when it changes its region, until it starts giving off terminal branches. And that. So you don't need to know a whole lot, except blood coming off the arch is going to go through the brachiocephalic trunk, through the carotid arteries, and also through the vertebral arteries up into the head. So carotid and vertebral arteries are the first 2 branches supplying blood supply, and this would be on the right side of the head. Your brain, critical. On the left side, there's also a carotid artery and a vertebral artery. Okay. As this tube carries on, after the vertebral artery, it's called the subclavian artery. Why? It's under the clavicle. It's sort of protected by the clavicle. They can pull it up here a bit so you can see it. but it runs in behind the clavicle, so it's protected by the clavicle. Crosses under the clavicle and over top of the first rib, and as that tube does that, so again, if you look in the lab, you'll see where the first rib is, you'll see where the clavicle is, as it crosses over that, the same artery now becomes the axillary artery. So in the axilla, so in front of the scapula, is the axillary artery. Same tube, same blood, going out to the limb. Okay. As you continue down, the axillary artery, just as it passes the border of a muscle called teres major, which forms the back part of your armpit, it changes its name again into the brachial artery. And now we're into the upper arm. Okay. So all you really need to know is these names and where the blood's going. But already we're into the arm. So far so good. If you notice, lots of little arteries coming off here, some curling around the neck of the humerus. I don't care if you know them or not. Okay. And you can see there's going to be a ton of arteries coming off in different areas, supplying the very region they're going to. These circumflex arteries are neat because they kind of surround the neck, the surgical neck of the humerus. So they're going to supply all this stuff in there. But you don't need to know those. Anything in bold, you do need to know. It's highlighted in a red box. So we get to the elbow. Okay. This is a newer version from the Moore. It's exactly the same figure you had in the previous one. I put in this in here to make a point. You don't need to know anything that's in this box. But one of the key things about the blood supply all over the body is there's usually two ways blood can get somewhere. And that's, if you just think of this, of the scapula, it's the medial border of the scapula, a blood supply can come around. And wherever these funny looking V-shaped things are, they're vascular beds that anastomose with arteries from the other side. Okay? So you've got blood supply coming to the back part, the infraspinatus fossa here, from one artery series and from another. So if anything should happen here, it gets occluded, the other side can fully function to supply blood to where that artery has been occluded. And this is a very important strategy throughout the body. Maybe Rob will talk about it more in 132. But usually, if there's an artery going somewhere, it'll choose two different branches to supply that area. Okay? So if you lose one, you can get counterflow from the other one. So it's a really important idea, but you don't need to know these different branches. Just need to know these guys, okay? So again, the brachiocephalic trunk comes off the arch. So we have a vertebral artery on one side, you have the right and left carotid arteries there and there, and the vertebral artery will come off on this side and go to the brain. As it comes off from the trunk, it becomes the subclavian, becomes the axillary, crosses the lower border of your armpit, becomes the brachial. And the last one that wasn't included in the previous one is profunda brachii artery. This one you need to know. It's the main branch of the brachial artery that supplies the back of your upper arm. So you have two arteries, one in the front and one in the back, that are critical, okay, in supplying blood supply. That's it. That's all you need to know so far to the elbow. Okay. We carry on down. You can actually have locations where you can feel the pulse of some of these critical arteries. If we pick it up here at the lower border of the axilla, there's the axillary artery, it becomes the brachial artery, crosses in front of the elbow, gives rise to the profundus on the back. As it crosses the elbow, now it breaks into two, radial and ulnar. One on the radial side of the limb and one on the ulnar side of the limb. And they come down and they form two arches in your palm that we're going to come back to when we start talking about the blood supply of the hand. Okay? So you have two ways now to shunt blood, through the radial artery on the outside of your arm, ulnar artery from the inside of the arm, and two arches. One is quite superficial and the other is deep. But again, if you notice, both radial and ulnar contribute to both arches. So for some reason, you had a lesion of the ulnar artery at your wrist. The radial artery could supply these arches on its own, could compensate for an occlusion. So that's the neat strategy the system uses. Always has these Katori beds that are driven by two ends of the arterial system. So if one gets sacrificed, the other side can compensate, especially around the heart. And you can feel the pulse of these different arteries in different locations. You can try that on the left. Okay? That's it. Those are the only arteries I need you to know for the arm. You don't need to know what's the blood supply of biceps, It's going to be brachial because it's right there. Right? But you don't need to know the blood supply of individual muscles. I don't care if you know that. I care that you know the tubes as they go from the heart into the hand. And there's very few of them. So that should take you no more than 10 minutes to memorize, if that. And we're going to keep coming up to them when we go to the elbow. We'll start bringing you back to the brachial artery. Get into the hand. We're going to talk about ulnar radial and the arches again. Okay? So that's how blood gets out. Blood gets back using the same tubes, same idea, not the same tubes, same idea, same labeling system. But what's happening in the deep veins here, this is a figure from your book. They might have a slightly different name. So vertebral and carotid are called jugulars. So they drain the head. So the jugular veins take blood from the brain and from the head and neck and bring it back into the superior vena cava at the top, which then dumps into your heart. That's how blood gets back. But all the names, the axillary vein, the brachial vein, the radial and ulnar vein, the arches, they're all the same name, and they match up with the arteries exactly. The difference is, when it comes to the veins, instead of one, there's usually 2 or sometimes 3 little veins around the artery, all with the same name. So around the brachial artery will be brachial veins, usually 2 of them. These 2 veins are interesting. They're called venae comitant. They can shunt blood between each other the whole way. So if, again, blood's having trouble getting up one part of the brachial veins, it can shunt blood over to the other brachial vein and bring it up. This is the whole deep system. So if you know the arterial names, you now know the brachial veins of the deep system for venous drainage. So the arches supply radial and ulnar veins that come up, become brachial veins. Profundus vein will dump into that. Axillary, subclavian, boom. Vena cava heart. So it's pretty quick to learn how to do it. And again, I've just put in here some nice figures showing you that the venous drainage is the same idea as the arteries. You can have an occlusion somewhere, and yet the other side can pick it up and bring the blood back to the heart. So it's a really neat system. Okay? So this is the venous drainage of the arm. That's all you need to know. And they usually come in pairs. So if you're dissecting a cadaver, you might find one brachial artery. Literally on either side of it will be the 2 brachial veins. Sometimes a third one on the back. That's how they shunt blood up back to the heart. Okay? In the superficial aspect of the limb, and again, whenever you see green tubes, it's lymphatic. You do not need to know anything about lymphatic drainage. You might find it interesting where the lymph nodes are, collection sites, etc. for lymph. I think you might learn more about lymph from 132. I don't know if Rob covers it. But the superficial venous system comes with 2 veins, cephalic and basilic veins. These are easily seen on someone's skin. The cephalic vein is from the outside of the arm, comes up, and has a little tributary that goes right across the middle of your elbow to join up with the basilic vein, which is the inside of your arm. That mediocubital vein is where the venipuncture is done. When you go to give blood, they go right across your elbow. That's where they're harpooning in. Okay? And it basically, again, allows superficial venous drainage from the cephalic end to jump across to the basilic side. If you follow them up into the arm, you follow the cephalic vein up, it's on the lateral side of the arm, curls around, and eventually dumps in to the basilic vein and the axillary vein at the same time, up here. Somebody in the gym who's really ripped, you'll see a big blue line coming up between deltoid and pectoral major. That is their cephalic vein. It's a really good place if you need a quick venipuncture. You'll pop right in there, okay? The basilic is more on the inside. It's harder to see, but again, if you got somebody who's really ripped, you'll see a blue line come up almost short of the armpit and disappear because it pierces the fascia to dump into the axillary vein. So both the basilic and then the cephalic dump into the deep venous system just above the axilla to bring blood back. So it's important to know these 2 as they represent the superficial venous drainage. You know the arteries going out, you know the names of the deep veins. Okay? That's it. That's not bad. Again, 10 to 15 minutes, just memorization. And you'll know all the artery supply and venous supply of the upper limb. Okay? This is the part you're not going to like. No one does, but if you chug away at it, you will learn all about the nervous supply of the upper limb. And that is the brachial plexus. I liken it to a highway. It's like a massive freeway. The job of the peripheral nervous system is to get these anterior rami from C5, C6, C7, C8, and T1. The main big anterior ramus that comes off the spinal nerve at each of these levels, from C5 to T1 in the spinal cord, out to supply the muscles of the shoulder and the arm. Okay, that's its job. So within all these anterior rami are going to be the motor neurons that go out to supply the whole limb skeletal muscle. It's also going to contain all the sensory fibers from the different sensors of the hand and forearm and arm that have to come back up through this maze to get to those different levels. Remember, it's coming from the thumb, that's C6 in the dermatomes. It means it somehow has to come in through this mess and eventually make it up so that the sensory fibers come in and go through the dorsal horn into the spinal cord of C6. So that means C5 to T1 in the spinal cord segments are responsible for your whole motor function and sensory processing of the shoulder and upper limb. That's why it's difficult. It's called a plexus because you can just see it gets really hairy. Okay. The point of this slide, before we go ahead and build this beast, is it's broken into regions, and just think of it from the colors here. Okay. And the colors all match up with the schematic, so you can get an idea of where these things actually line up with regards to the neck, the clavicle, the axilla, and then into the arm. Okay? And they all change color. So the first thing you need to know is that there are 1, 2, 3, 4, 5 distinct colors. And the first one are these purple ones. And these are called the roots, R-O-O-T-S. Nerve roots, makes sense. And they combine to form trunks, which are the orange ones. There's 3 trunks, a superior, a middle, and an inferior. Each one of these trunks then bifurcates into divisions. So we have roots, trunks, divisions, anterior and posterior divisions. Next, everything combines in a different pattern to form cords. Okay, you have a lateral cord, a posterior cord, and a medial cord. They must be named that for a reason. Just like these are called superior, middle, and inferior. Sometimes you'll see people call them upper, middle, and lower. You can either do one if you want. But they must have a purpose for having that name. And lastly, all these cords shrapnel into these green lines here, which are the critical branches that go into the arm. So you can think of the brachial plexus as having these 5 different regions. And if you look at your schematic, the roots are right up in the neck. They have this culmination of these trunks, which are still above the level of the clavicle, but they're going to be in here. So if you need to get into a trunk, you can go in above the clavicle and get into that nerve. There's a problem there. The ones that are hiding behind the clavicle are these divisions. It's harder to get at. But as you get into the guts of the axilla, we now have these cords, these 3 cords. And then finally, you have terminal branches coming off and supplying very distinct groups of muscles in the arm. Okay. There's a whole list of them here. These are the different nerves that go to distinct muscles. And I'm going to slowly build this thing out for you so you can see where they go. Okay, roots, trunks, divisions, cords, and finally terminal branches. What I've done is I've used Hollinghead's figure because it's the flip side. Make you think a little differently. Instead of the right side, this is the left side you're now looking at. It's the same thing. Here, Hollinghead has used upper, middle, and lower instead of superior, middle, and inferior. Again, it doesn't matter. Roots, trunks, divisions, cords, and branches. And again, it's formed from the anterior rami of C5, C6, C7, C8, T1. These are the roots that all come together to start this beast. Remember, each level will have a dorsal root, or a dorsal ramus. Will supply the back muscles at the same level. But the anterior ramus is way bigger because it's carrying all the motor supply and bringing back sensory supply for your upper limb. It's got to be bigger. Occasionally, people will have a C4 contribution from above or a T1, T2 contribution from below. It's rare, but it happens. There are a couple of cadavers in Queens who are going along and we're dissecting the brachial plexus going, whoa, this is C4 to C8, not to T1. And one went from basically C5 to T2. So it had a much bigger, broad. It happens rarely, but it does happen occasionally. About 5% of people have what's called a supra or infra expanded plexus. You don't need to know that, you just need to know commonly this is what you have. Most of you. So let's build it. So whiting out everything else for now. Here we have the 5 roots, C5, C6, C7, C8, T1. They come out, and the first thing you notice is 2 little branches come off, one up high, the one is the combination of C5, C6, and C7. Gives rise to a nerve right away. Okay. This nerve is called the long thoracic nerve. That means wherever it's going to have motor neurons from C5, C6, and C7 coming into it. And in fact, it's going down the side of your rib cage to supply your first muscle, the serratus anterior. You'll hear about what it does next week. That's it. That is the nerve supply for serratus anterior. On the top, what's called the dorsoscapular nerve is blowing off C5. Where is it going to go? It's going to supply 2 muscles on the medial border of your scapula, called rhomboid major and minor, sometimes a third one. But they come off right away before we started to dance with these cords and trunks and all that stuff. C5 and 6 will come together to form the upper trunk. C7 and C8 and T1 will come together to form the lower trunk. And C7 just continues on to form the middle trunk, like this, okay? Or upper, middle, and lower. So 5 and 6 combine to form your upper trunk. C7 continues on as the middle trunk. C8 and T1 now merge together to form the lower trunk. So whatever motor neurons are in C5 and 6 are actually coming together commonly into this area. Again, coming off this upper trunk now comes another nerve. It's called the suprascapular nerve. It supplies 2 of your rotator cuff muscles, supraspinatus and infraspinatus. So all the muscles are in red. That's why I think once you start getting into this, go back and look at these slides in series, you'll be able to figure out all the muscles that are tied to the different nerves. Okay? Now, the next thing these upper, middle, and lower trunks do is they divide. And interestingly enough, they divide in what are called divisions. One's called the anterior, one's called the posterior. Why? Because one division is on the anterior surface, and the other is on the posterior surface. So it goes backwards instead of forwards. Interesting. 2 anterior divisions, the one from the upper and the one from the middle, they come together and form the lateral cord. The lower 2, or the lower 2 where C8 and T1 had become the lower trunk, it just continues on, the anterior division just continues on as what's called the medial cord. And all 3 of the divisions from the posterior, the one from C5 and 6, the upper trunk, one from C7, the middle trunk, and the one that comes off C8 and T1, all 3 of these posteriors come together, thank God, and they're called the posterior cord. Okay? Why? Because the lateral and medial one supply the front of your arm and your forearm. They're on the anterior surface. So anything, biceps, anything on your forearm is supplied by one of those 2. That's why they're white. The posterior one, that is basically the posterior cord that forms posterior divisions, supplies everything on the back of your arm, triceps, all the wrist extensors, fingers extensors. So from the anatomical position, now your brachial plexus is broken into basically two cords, the lateral medial that supply the front of the arm, and the posterior one that supplies all the back. So it's a really handy labeling. And why are they called that? Because right in the middle of this sucker is the axillary artery. they're labeled as lateral to the axillary artery, medial to the axillary artery, or posterior to the axillary artery. That's why they have that name. Pregnant pause. Okay? Not that bad, is it? Seems like a lot, but as you go through this, you'll start to see, okay, and why? Why do all this? Well, so far, you could have a motor neuron in C5 that could go to the dorsal scapular nerve, it could carry on into the suprascapular nerve, or it could come down, it could become a part of the posterior division into the, now it's going in the back of the arm, all from C5. In fact, if you look at them, everything from C5 to T1 can somehow make its way into the posterior. And that's what they do. So a lot of the upper arm and lower arm muscles actually have contributions from all of those spinal cord segments. That's why we have this mayhem going on of things crisscrossing. It's a quick way to shunt different spinal levels to different areas of the body. It's like a freeway with off ramps and on ramps, side streets. Okay? The last bit gets a whole lot of muscles because we're going into the terminal branches and other branches that come off either the lateral, posterior, medial cord. So, coming off the lateral one is a thing called the lateral pectoral nerve. Okay, so lateral pectoral nerve, I've got in red here pectoralis major. Actually, Moore says it supplies both pec minor and major. That's all you have to remember. It's all on a beautiful table telling you which muscles are supplied by what. The musculocutaneous nerve, a terminal branch, a big one, actually supplies all the elbow flexors. Coracobrachialis, biceps, short and long head, brachialis. Okay? They're all going to be somehow supplied by that nerve. And as we get to the muscles, you see where the nerve comes into play. If you damage that, you have paralysis of these. That's pretty serious. Okay, very weak elbow flexion. The median nerve, terminal, it's got a whole contribution from the lateral cord, whole from the medial cord. Okay, it's going to go down. Major supply of the arm. We don't talk about it here because we'll get into it as we get into the forearm. The posterior cord here has three big nerves that come off, upper and lower subscapular. That should tell you what they supply. So the subscapularis muscle. And one in the middle. I think it's called thoracodorsal. You just have to memorize it that it goes to the latissimus dorsi muscle. So now we're supplying all these big muscles as we jump into the arm. Okay, so they all come off, those three come off the posterior cord. Posterior cord continues on as two nerves. Axillary supplies only two muscles, teres minor and deltoid. The radial, the radial supplies everybody. Upper limb and back of the forearm. It's a big nerve, in fact, it's the biggest one you've got in the upper limb. Okay. Finally, the medial cord has three other nerves that come off. I don't care if you know the two cutaneous ones, then I'm not concerned with cutaneous, but the one you should know is the medial pectoral nerve, because it's supposed to supply pec minor, but like the lateral one, Moore says it supplies both. So lateral and medial pectoral nerves supply two muscles each, that same two. The pectoralis major and minor, that's all you have to remember. You just covered the nerve supply pretty well everything. We haven't gone into details about the radial, the median, and the ulnar, because they're basically from the elbow down. They cover everything. That's why they're called terminal branches. Okay? So everything in red is a muscle that you'll learn about, and these are the branches that supply them. So, let's see, I think I covered it again. Don't need to know those. Don't need to know that. And here's the ulnar nerve. And we'll get into where they go, and you don't need to know their relative orientation with regards to the skeleton, except kind of nice to know that the roots are up here, terminal branches at the lower part of your armpit. So somewhere between the clavicle and your armpit is where the real meat and potatoes is occurring around the axillary artery, and the terminal branches are created out here. Okay. And that's it. That's the whole shooting match. And I think it's neat functionally if you can remember that this posterior, okay, cord is the back of the arm. It has to supply all the muscles in the back of the upper arm and back of the forearm. And then the lateral and the medial ones come together to form some critical branches down here that supply the front of your arm and the front of your forearm, and actually ulnar and medial, all the muscles in your hand. So you learn about all the little intrinsic muscles, probably after the midterm, that are supplied by those two nerves. Okay. Frightening, but you should be able to grab a whiteboard and schematically trace it all out. If you're curious, clinical anatomy has a, what are they called? They have a video, first off, they have the best video going on the web of the brachial plexus. And actually what Claudia does, it's very thematic. They spend about $5 or $6 grand on this. So the video opens with someone playing a violin. And Wayne Vogel, with his little glasses on and his tuxedo, gracefully comes in and describes the instrument playing the instrument, which is interesting, because the fidelity of your hand depends on that. Claudia then goes in and she draws the whole thing out for you on a whiteboard, kind of using computer room, which is exactly the way they used to teach it. That's the way I learned it. I learned it by someone on the board drawing the thing in front of me and then having to duplicate that. Part of my comps in anatomy, I had to draw the whole thing up on a board, piece of chalk. Draw the brachial plexus. Okay. So you can do it. Right? The second half of the video, they show you a prosected limb where Wayne takes you through the whole cadaver, showing you where the brachial plexus is and where the different nerves go to these different muscles. It's a beautiful video, and there is a whole module that you can go into that will take you through this again. So once you think you got it, once you think you're confident you know how to do this, use those two resources, and you'll be able to confirm, or at least convince yourself that you've missed something. And in Claudia's version, there's one little branch in here that's not in Moore. So if you pick it up, you just have to know the version that Moore gave you, okay? Which is basically the same as this one. Stunned silence. I love this lecture because it's the worst one you're going to face all year. It's intimidating, but you'll do well. You'll figure it out. It's not going to take long, I promise. So we did talk about dermatomes, right? This is a figure that's right after the brachial plexus. There's two kinds. This big one that I've circled in red is the preferred version. This is the one that's based on clinical diagnosis. Because we're a warring species, we like to damn each other in war. We create all kinds of very interesting lesions. World War I was amazing for understanding the nervous system from a central nervous system issue and a peripheral nervous system issue. Tons and tons of spinal cord patients and peripheral damage to limbs that created paralysis that was spotty, sensory sensation that was spotty. It created a clinical picture for a neurologist who then figured out, this was I think 33 or 34, by then they figured it all out, that if you have these different regions of skin and you touch them, it's because those receptors went to very distinct regions of the spinal cord, the dermatome. So the only thing you need to know is this preferred version on the anterior view and posterior view, and it's dead simple. You touch my shoulder, it's C4. You touch the outside of my arm, it's C5. You touch my big pointy thumb, C6. Touch my middle finger, anywhere, it's going to be C7. Touch my baby finger, it's going to be C8. Come up my arm, the inside of my elbow, T1. Inside of my armpit, T2. That's it. And by doing this, saying yes, 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 nope, 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 you now know what level of spinal cord has been damaged. That's the dermatome. And this pattern is the one I prefer you to know. Cutaneous nerves, another dreaded figure from Moore, is anything above the wrist, you don't need to know that. There's a ton of nerves in there that'll eventually all connect up with what? The brachial plexus. Has to. You will know the hand. It's only 3 nerves, ulnar, median, and radial. But it presents with these different colored images than you would see with a dermatome. And the important thing here, still cutaneous sensation, but it's coming up the nerves that eventually get to the different levels of spinal cord. So if I have a problem sensing the outside of the base of my thumb and the back of my thumb and back of my half of my hand, but I'm okay at my fingertips in the back and my thumb in the back and the whole other fingers at the back. That's the problem with the radial nerve at the wrist. It's not a problem with the dermatome. My whole thumb is gone and it's presenting as if it's a dermatome problem. That it's going to involve multiple peripheral nerves as well. So you can use the two to determine, is the damage at the spinal cord? Is it presenting like a dermatome? Or is it presenting like a cutaneous nerve that's been cut? If this whole purple area on the front and those dorsal parts of my fingers and thumb are numb, that's the median nerve. It's paralyzed at the wrist. It's not a dermatome, it's just that skin is not getting past the wrist and getting up to the dermatome. So if you check the rest of the stuff supplied by C6 and C7, you probably find they were just hunky-dory, they were fine. So the damage was somewhere right at my wrist. Carpal tunnel syndrome. Yep.
You need to know the dorsal cutaneous nerve, that's like a branch that's above the red box, but pointing to the below.
This thing?
Yeah.
Yes. Yep. Because it's basically anything below the red line are these branches from radial, ulnar, or median nerve, like that. And I'm going to go over this when we get to the hand. Again, we're not going to get to this till after the midterm. But I want to totally dissuade you, if you get into reading all these different cutaneous nerves, you do not need to know them. In medicine, you will. You'll have to. But not for this. The only cutaneous innervation I care about is the hand, so you can compare it to dermatomes and quickly assess someone. Do you have damage in C5s? No, C6, C7, C8? Or is it a peripheral cutaneous problem? It's a hard concept, but you need to get it. Okay? So, I strongly recommend you take advantage of Friday's holiday or reflecting. That's digging into the brachial plexus. Because if you remember the nerve supply for pec major, okay, and then you figure out where pec major is and what it does, you've just completely got what I need. The muscle, its attachments, don't care if it's proximal distal, its nerve supply, and then lastly, what does it do? So that's the course. Every muscle. If you can do that, you've got it made. Okay. So starting next week, I'm actually going to start throwing in a few questions each lecture so you get an idea what the midterm will be like, and I'll start talking a little bit more about what the nature of the midterm will look like for you. Okay? It's not going to be an essay. Okay, enjoy Friday.